Hey, welcome back for the part two of this video. Um, yeah, I just finished uploading the first one and just getting the feels out, how it looked. So, looked okay. I think I did an okay job in that one. Um, but yeah, that's just my current mental model evaluating. Let's see after n number of days, maybe let's say after 3 months, maybe we can circle back and see how it goes. All right. Now I'll quickly share my screen again. We're recording and jump to section 3, which is the proposed taxonomy that we were discussing for the paper. Now, while new principles are needed to evaluate AI for mental health, there is much to build from the century of work in psychological assessment. Um, this would be classical quantitative methods, and oh, this is new for me as well. Am I a good researcher? I don't know, but this is good for me as well. Um, I will not go into the details and the fine details and the depth to open the paper and read, but we'll learn at a very high level for what this is. If later, if anyone wants to go deep into it, you guys can look this paper up, read it on your own. I'm reading it on Alpha Archive, which I didn't mention in the last video, but this is like what um, it's really cool. I'm pretty certain most of you would be aware of this. I've been using it for quite some time, would and so would you be like, and so you would you or you would, I don't know. And so would you. But the main idea is that you can move your papers into certain folders, and it helps you keep accountability. There's also an AI feature for this. So this is like a free paid promotion, not a paid promotion, but free promotion for the platform. If I have any um, followers. Yeah. So the recent, so we can build on the psychological assessment and um, of psychological assessment of like the classical quantitative methods and recent advances in applying technology in human computer interaction and health implementation science. One very interesting anecdote that I would like to share is that I took this human computer interaction course at UMass Lowell, and one of the questions that I asked to my teacher, my professor, was, is there like how does she feel the interaction, the human AI interaction is going to look like, and AI interaction is going to look like, and how can we build systems where humans are um, more secure, more like they can feel more grounded in that human AI interaction kind of a world, because that's what we will be dominated on. Even a lot of the structure of the web is was optimized for human clicks and everything. Now behind the APIs, everything is changing. It's more structured. There's more structure to the data. HTML and CSS content might go not like will go down, but it'll become more generic, and exchange and information heavy pages might come up because those will be passed through the APIs. When a lot of information is being parsed, the volume of data being transferred in the networks will increase. How can we build reliable systems which are full of encryption as well to safely transfer data? Of course, there are TCP protocols and different protocols to take care of not if not the encryption, but the data transfer. But this is also like altogether a separate field, and I've wanted to ask my professor as to what she thinks about that. So that is one of the things I am excited about. If you are, send me a message. I think my email would be public, my LinkedIn would be public, everything's up there. In this video, I'll be also adding my social. So let's see. Okay, now I do not know how to turn this up. Can I? Can I rotate this somehow? Please. Let me see. Probably not. Yeah. All right, so we have, let's look at this. This is a taxonomy for evaluation of AI and mental health applications, aligning support types with validity, reliability, implementation, and maintenance across various contexts. Now we have support type, we have assessment, intervention, and information synthesis. Now these are the three things that this paper will be focusing on. Assessment is how we can understand um, understand the mental models. Like, are we able to diagnose? So that's like one of the things. And if we look properly at this, how much does it match other tools or indicators? Example, clinical, community, or self-report measures intended to assess. Okay, let me do one thing. I think this is not helping me, at least me at all. Um, Let me do this. If I can copy this, I can do that. Drop it in here. Is there a way to rotate this? View, uh, somewhat. We're getting there. We'll get there eventually. Okay, what about this? Probably not. Um, can I insert something here? Okay, let me do this. This will save. And now I can rotate, go here, zoom in. There you go. We're figuring stuff real time. Let's go. Let's go. Okay, so we have um I think this should be visible. We have assessment, we have language-based screening. Does it do so? Like, we have the quality criteria and real world use case. Okay, so these are the two metrics, themes essentially. Themes, yeah. Construct validity, how much does it match other tools or indicators? Example, clinical, community, or self-reported measures intended to assess the same construct or a different construct. We have the criterion validity. What is its association with external theoretically related constructs or outcomes? Example, well-being, functioning, participation. Quality criteria. Does it do the same thing under different conditions? Okay. Uh, so assessment. What is a test retest stability at appropriate time intervals? What is the test retest stability? Oh, and okay, makes sense. So like if you test it at one point in time and in the next point in time, is it a similar, like, is it like, does the test hold up or not? Does it change, or should it, or should not? Across populations, does it work just as well across different cultures, locations, neurodivergent populations? Internal consistency, to what extent do all components or interactions of the tool function consistently? Interesting. So like, if we are using a tool, it could be a chatbot, it could be any other thing. Like, is it adaptable, which is the reliability component, and is it valid? Is the construct valid? Is the criterion valid? Like, what is the association with external theoretically related constructs or outcomes, well-being, functioning, participation, and how much does it match other tools or indicators? Okay, so if we are proposing a new form of evaluation, does it align with the already existing constructs? Does it hold to their principles or not? And is it valid? Um, so yeah, the main idea is the validity over there. Um, so and we have reliability. But in real world use case, we can check for feasibility, effectiveness, and usefulness, acceptability, generalization, and impact, and unintended consequences. Is it creating labeling bias? So like these are one of the, like these are few things. But like this particular thing I would strongly argue for, because a lot of the times our evaluation criteria can be biased when we are focusing on a very niche problem. So let's say I'm focusing on insomnia, my evaluation might not be generalizable to other things, but would be generalizable, not generalizable, but will introduce labels specific to insomnia or sleep. And um, sometimes, because mental health and other aspects of uh, like AI for mental health are very convoluted and interconnected, we can end up evaluating across certain similar labels, certain similar, um, like we can end up optimizing for certain labels or certain classes or certain aspects, which can create bias. So like this is a very important thing that we need to be aware about. Now, does performance remain stable as users or context evolve over time? Now, this was a point that I initially brought up in the previous video as well, because this is the core crux of the problem. Not just people, since people are evolving, the demographic changes there. Your chatbot should be doing retraining, right? Because the data is changing. But if it's not just that, the evaluation should also change. Maybe, let's say after 10 years, there is a huge population which is more anxious, which has more angst in them. They are uncertain with the AI world, and like I don't know, like there have been studies, and I'm not promoting any pessimistic view, but there are studies which do show that people are, especially like in one particular, like in a field which which could be replaceable, they people tend to focus on the negative aspects more. This has been proven in the psychological worldviews as well. Now, if that is the scenario, then there could be a case where population might become more negative, more disenchanted. There might be some fear involved. And the AI systems, let's say we're evaluating four different aspects equally, but it could be necessary that evaluating fear more, or giving weight to fear more, might be better for models or not. Now, I'm not saying any of this is correct. This is just a guess, but you can see that the demographic can change in a way which might involve change in the evaluation as well. Um, and now, if we talk about intervention, does it now intervention is the way which we deliver the therapy? It could be therapeutic chatbots, right? Does it make a change in the intended direction? Um, does it predict or improve external downstream outcomes, right? So like these are the ways in which we want to check the validity. And stability would be, and basically stability or reliability would be that across time, does it keep working as well as future points in time across populations? Is the effect the same across cultures, locations, neurodivergence, and internal consistency of it as well. But when it comes to real world use cases, when we talk about it, the implementation, how effective it is, how you like what can we comment about the usability and engagement, the implementation risks, equity and acceptability? Do diverse user groups find it acceptable and trustworthy, or are there potential biases that need to be mitigated? Similarly, when we talk about the maintenance, we have stability and safety. So, like these are different aspects. The final would be information synthesis, which is consolidating all the information. It could be the task of clinical summarization as well. Now, when we talk about the validity, we talk about construct validity. Does it provide accurate, contextually appropriate, or unbiased summaries and recommendations? These are different components. Well, these are the underlying theoretical um, requirements that we need to do let's say for the task of summarization, that it should be consistent with what we are presenting, and it should not introduce any biases. Then information synthesis, if we talk about the stability and the reliability of it, we can focus on scenarios and services. is it reliable under different scenarios? Is it reliable under different services? Effectively across different service models or modalities. Now, these are certain aspects when summarization and information synthesis, not just summarization, needs to be valid overall in general. And when it comes to real world use cases, acceptability, usefulness, impact would be within the pipeline, downstream of the pipeline, um, and like, is it actually capturing what's important, what's necessary? Equity and bias mitigation. Are there systematic biases and recommendations or summaries? Are they identified and mitigated? Now it could be two-level impact. Does it reduce administrative load? So let's say if we are doing the task of medical summarization, summarization is really useful. I've talked to multiple doctors and they said that most of their times get spent on paperwork and all that stuff. So if we are using AI for mental health, and if there's an automated note taker, it could be a case that the therapy session is being conducted via Zoom in this modern world. And when that is conducted via Zoom, a lot of the not a lot of the times, but there could be cases where the handwritten notes might go missing. Then if you have an automated note taker, that can make summarizations, but it can also introduce biases. So that would be the safety aspect that we need to take care of, which is also mentioned over here in unintended consequences of this particular segment. So given this understanding, we can go ahead and read um, more about the classical quantitative methods and the implementation science, the interventions, and the information synthesis. So when we look into the classical quantitative methods, now validity and reliability are foundational in psychological evaluation. Now, this are the foundational principles that we need to take care of. And validity asks whether a tool does what it is intended to do. So let's say if there's a task of, let's say my task of building a chatbot for insomnia support. So does the chatbot provides insomnia related support or not? Now validity asks whether a tool does what it is intended to do, and while reliability asks whether it does so consistently. Now, most current evaluations in AI for mental health focuses on one validity subtype, namely construct validity. For example, through agreement with human annotations or existing scales, but this is only a starting point for high stakes applications. Now, a classifier may correlate with overall depression severity. It failed to predict specific symptoms or generalize across populations. Similarly, a summarization tool may align with expert summaries but omit safety critical information or misinterpret non clinical expressions. Now, this highlights limits. This highlights the limitations in the discriminant validity and generalization. And near perfect construct validity is not always desirable, as well as even established assessments have limitations. When we talk about the implementation science, there are recent advances with the help of AI that go beyond um, validity and reliability. Implementation science also adds two pillars. One is the implementation, which is whether the AI tool being used is feasible and acceptable. Does it fits the workflows better, or are the outcomes better? Like once we use this, and the other one is how do we maintain? Um, is it adaptable to the drift that happens? It could be language drift, it could be modality drift, it could be other inequities or other worldly um, real world messy scenarios, and how adaptable it is. So there is implementation science to that as well. Now, together with validity and reliability, these four pillars determine a multi-dimensional evaluation space for AI in mental health across assessment interventions and support synthesis. Now we can think about this in terms of like a system design problem. If we are trying to solve the problem, firstly we'll ask, is it solvable? How do we solve it? Is our approach of what we are building and what we are evaluating, is it consistent with what already exists in the literature or if it is introducing something new, what are the fundamental components it is introducing, and what kind of biases or new aspects of evaluation we need to consider to take into account the holistic evaluation of this that maintains consistency and reliability across different scenarios. And these scenarios can be different mental health tasks, different administrative or information synthesis tasks. So, like, these are different kinds of things. But let's say once the intervention is being like once this sort of structure is fixed, then comes the more system design, the more product scalability components, which would include, are we building a system which is adaptable? Because drift will happen in real world scenarios. Is it generalizable? Is it safe? Does it introduce any unintended consequences? So these are certain kinds of things we need to be um, cautious about and take into consideration while designing systems and also evaluating systems, because this paper is about evaluations. So to organize these concepts, we introduce a taxonomy of evaluation dimensions, which is mentioned in this table 3 raised to the power 6. Mapping classical psychometrics and implementation science principles. So they are merging the classical psychometrics and implementation science principles into common AI applications, assessment, intervention, and information synthesis. And these evaluation paradigms are multifaceted. No single score can capture the full opportunities and risks of AI, akin to a cockpit dashboard where multiple readings are needed to assess the performance. And some of the times, based on the scenarios, as is very frequent with machine learning, there can be scenarios where, let's say in classical machine learning, there can be scenarios where recall is needed or precision is needed when we are doing a classification task. Then the evaluation is fixed, but we need to pick and choose which is better. The same should be applied for, um, but in a more convoluted way, should be applied for um, AI for mental health, because now um, it's more convoluted, it's more interconnected to a lot of different things. Maybe the model scores well on certain aspects. Maybe, let's say, one aspect is emotional conversation. So one topic in AI research is emotional support conversations. Maybe it does well on that, but is it able to maintain long-term memory? Might not be. So I think these are certain aspects which we need to pick and choose. It's like cherry picking for your own particular task. So I think that is the main idea. Now, when we talk about the assessments, assessments involve tools for measurement, screening, aiding diagnosis, and forecasting. Examples scoring depression severity, estimating suicide risk from social media, classifying psychosis related language, and validity focuses on convergent validity, alignment with other measures of the same construct, discriminant validity, avoiding spurious alignment with different constructs, and criterion validity. Now, this is important. I read it and just flew by it. I need to focus on this. So, validity focuses on convergent validity. Now, this is an important term, which would mean alignment with other measures of the same construct. Discriminant validity, which is avoiding spurious alignment with different constructs. So this is tricky. Even in research, it's actually very tricky. Now, um, discriminant validity is basically now two constructs can be overlapping. We need to define variables and define boundaries between them. So there should not be alignment with different constructs. The constructs themselves should be different, and especially in mental health, things are related. Even in therapy, when we talk about therapeutic conversations, what usually happens is that we are having a conversation and we are trying to draw patterns from our own particular cases, and even the therapist is trying to draw patterns, right? So when all of these things, like, we're trying to make sense of our inner world that does not make sense. Similar problems can appear in research as well, where one of the like where few things are, if you're trying to define certain variables in terms of, let's say, evaluation, as this paper is presenting, we can define In our minds, two constructs can be different, but for another researcher, two constructs can be overlapping. It's always a Venn diagram, and we need to define certain constructs that do not have like this alignment and has like common consensus. Okay, these are explicitly different. For example, empathy and honesty are totally different, but empathy and care might be overlapping. So take it with a pinch of salt. And if you're trying to do research, and this is what I've been doing wrong in my 1 year, um, focus on these components. Very important. Now, avoiding spurious alignment with different constructs and criterion validity. Now, relation to meaningful external outcomes like hospitalization or symptom trajectories. Biggest problem, time series. How do you, like, it's like not time series, it's like time series data. How do, how does your system impact outcomes? No way to estimate that. It's an NP hard problem because even if you try to model the human brain, which I've been trying to do for past 1 year now or 6 months, there's always like you do not know that if you are defining a human brain under certain variable conditions, if certain variable receives an activation, does that activation translate to the necessary outcome or not? For example, how much therapy impacts the trajectory? Let's say if you're designing an AI chatbot for therapy, what you would ideally want is that you would want to evaluate your system under the lens that therapeutic outcome or the therapy session impacts the next 1 week or 2 weeks of the person's therapy. Seems like a reasonable assumption, right? Not how do you model that? Very difficult to do. It's a very, very hard problem. We can do simulations, and I've been trying to do that. If you have any ideas, hit me up, please. I would love to do that, but it's a very hard problem to solve. And so criterion validity, like how does your evaluation basically attack, like if you're building something, or like how does your evaluation relate with external, like meaningful um, real world settings? So like these are different components. Now the reliability covers stability over time, which is test, retest, robustness across populations, internal consistency. Now these are certain things which standard software engineers do take into account frequently. Now implementation examines feasibility, impact on diagnostic accuracy, equity, acceptability, and bias mitigation. Maintenance involves monitoring generalizability, performance drift, and population level outcomes, unintended consequences, and evolving language norms. And these are all the things that we discussed when we were looking at this table over here. You can scroll back in the video if you missed some component of it, but um, I would strongly recommend to read along because it's also my first video. I might not be presenting or clearing things up in a very neat way. So let me know in the comments if you feel like that. Now, the reliability covers stability, test, retest, robustness across populations, clinics, demographics, and all that stuff. Now, interventions are tools aimed at changing outcomes, such as treatment agents, self-help aids, preventing nudges, or adaptive therapy recommendations. Now, validity includes construct validity, delivering the intended therapeutic ingredient. Efficacy is producing beneficial change and avoiding harm, and criterion validity, predicting improvements in functioning relationships and or job stability. Reliability examines whether effects hold across time, population settings, and and intervention components. Implementation considers real-world symptoms, improvement, user engagement, clinician usability, low risk, and monitoring off-label use. Maintenance evaluates persistence of benefits and emergence of new risks such as overuse or avoidance of human care. Now, if we talk about information synthesis tools augment care administration efficiently for automated care aids, clinical summarization, triage notes. This is what we talked about, the note taker. Conversion validity asks whether outputs are accurate as per clinical evidence base, while while criterion validity asks whether they save clinician time and improve documentation. This is like a clear taxonomy that they have to find. Implementation focuses on acceptability, usefulness, and daily work, and patient impact. Maintenance considers tool level effects like reduced burnout or unintended consequences, over reliance, skill atrophy. In our evaluation framework, we prioritize these evaluation dimensions because they draw from long-standing clinical science, validity, and reliability, and real-world mental health technology evaluation, together defining minimum requirements for responsible use in high-stakes mental health contexts. So across all of these, which is the validity and the reliability, the implementation, and all that stuff, I think the general sense is quite clear, which is we need our evaluation pipelines to be consistent, to be relevant, and should have the meaningful clinical outcomes or should correlate with those while being robust, should survive the test, retest thing, sh and should help more logistically. Let's say if we are focusing on the information synthesis component, which is summarization, so should really impact and assist downstream use cases, maybe administrative use cases. So these are certain things that we need to be cognizant of while designing our evaluation pipelines. Now, when we talk about the case studies, now the following 5 case studies are selected to illustrate the taxonomy across the board types. They were chosen for their representativeness, methodological rigor, and the variety of AI approaches they exemplify. And this enables comprehensive demonstration of taxonomy's dimension, which is validity, reliability, implementation, and maintenance. So these are the taxonomy's dimensions that we need to take care of when doing the assessment. So this study was LLM rating scales for psychometric assessment of patient engagement. Now, this paper cites a particular research work introduced LLM rating scale, which is a psychometric tool for automatically transcribed psychotherapy sessions that measures latent psychological constructs such as patient's engagement by applying traditional psychometric principles to AI-based assessment. Now, the scale uses structured item prompts. Please rate how motivated the patient is to engage in therapy on a scale from 0 to 100. Now, this is zero shot, quite straightforward to elicit zero shot judgments from the model. The study analyzed 3-month sessions from 115 patients using Discover framework, computing mean scale scores from a large pool manually developed items, which were then evaluated for reliability and multiple forms of validity. I think we can all see the problems with this kind of an approach, but worth a try. We definitely need like a large scale study. Validity was assessed across multiple dimensions. Construct validity was supported by moderate to significant correlations between LLM rating scores and engagement determinants like therapy motivation and between session effort. This is interesting. Between session effort is very crucial in finding out the motivation, because what happened between the sessions will inform the next session as well. Criterion validity was shown through associations with subsequent therapy outcomes, where higher engagement predicated greater symptom improvement. Structural validity was evaluated via multi-level confirmatory factor analysis, modeling a single latent factor with good fit through RMSEA. Okay, a confession. I don't know what this is, but hopefully in the next video I can do that. So I'm gonna mark this, what this is. So I might not be able to explain this. What I'm gonna do, I'm gonna understand this and give a proper explanation in the description, what it means and what my interpretation of it would look like. So the reliability was examined as consistency of the measurement across time, across items with internal consistency. This is also something that I need to understand. showing coherent and stable LLM responses. The study demonstrated the psychometric soundness and potential of LLM rating scale as an automated tool for psychotherapy research and feeding and feedback. Future work should extend analysis across times and populations, assess robustness, fairness, and safety. Um, Interesting. Study to assess focus on natural language response formats for assessing depression and worry. Guinal conducted a validity and reliability based comparison of response formats of LM based assessment of depression and worry, building on prior work showing AI language assessments can approach the reliability of human scales. The study compared four response formats from closed to open using sequential evaluation with model pre-registration design. Again, no idea what this is. Models were trained on development set of n equals to 963 and pre-registered before evaluation on a prospective test set of 145 with validity scales including the PHQ-9 and GAT-7. The results showed strong convergent validity across formats with correlations of R 0.6 to 0.79, exceeding the pre-registered threshold. Combining all 8 depression and worry scales yielded correlations near or above scale reliability limits. An incremental validity analysis showed improved accuracy consistency with cognitive interviewing theory. Interesting. I might have an counter argument to that. However, high intercorrelations among combined models indicated reduced discriminant validity when the same responses were used to assess. Yeah, yeah, I think this is somewhat what I'm talking about. But I do not want to comment on this video without understanding it completely. Now, regarding reliability and implementation, 2-week test retest correlations showed moderate to strong stability, while performance generalizing well on unseen data and prospective accuracies matching cross-validated estimates. Open-ended formats showed internal consistency at the word level, with depression, example blue, and worry-related terms aligning with DSM-5 symptom clusters. Okay. Implementation effectiveness was demonstrated by predicting behavioral indicators such as sick leave and mental health related healthcare visits, often matching or exceeding standard rating scales. Feasibility analysis showed that open formats provide richer information, Shannon diversity up to 561.0, but required longer completion times, up to 4 times slower than selected word tasks. Overall, within the proposed taxonomy, this works shows strong conversion criterion and external validity and temporal reliability, indicating that well-designed LLM-based assessments can rival traditional measures. So I think this is an important finding, even for my work, and I would love to read more on this to give a better, to paint a better picture. But what they're essentially saying is that if the LLM based assessments, like if it's well structured and it's um, uh, yeah, if it's well designed, and they can measure the rival measures as well. However, discriminant validity and workflow feasibility remain open questions. Yeah, motivating future work across population reliability. Yeah, hmm, interesting. When we so here they talk about intervention, and here they do clinically grounded framework for evaluating LLM assisted cognitive restructuring. Oh, this is very now this is super important. Evaluating the capabilities of audience versus human to generate personalized intervention. So this is like how do so the earlier was diagnosis and maintenance and stuff. This one is how in terms of intervention, you go to therapy with a like with a proper therapist, a human therapist, and another is an AI chatbot. Now, evaluating the capabilities of LLMs versus human therapists to generate the personalized intervention. So, if a human being recommends something, or you have a conversation and how that conversation will be evaluated for that human, and how the conversation will be evaluated for a particular, let's say, using a chatbot. What are the differences over there? So Shachar, an all-developed LLM-based tool for generating context-sensitive therapeutic interventions during psychotherapy sessions. It uses four specialized LLM agents: supportive, directive, exploratory, and meaning-making. Now, this is a very important work, even for my own case, along with Judge LLM that selects the most appropriate intervention based on the dialogue and the patient's emotional and cognitive state. How do they model that? This is crazy. I do not know. This setup reflects how this setup reflects how clinicians choose among multiple interventions and tailor responses to patients' evolving needs. They evaluated the tool via human AI comparisons on transcribed therapy segments with both therapists and AI generating interventions that expert clinicians rated for therapeutic appropriateness, contextual fit, and helpfulness. High inter-rater High inter-rater reliability (ICC) and Cohen's kappa supported robustness, and AI interventions were generally clinically relevant and sometimes approached human quality, though they lacked the depth and personalization to of experienced clinicians. Applying the taxonomy shows strong construct validity and reliability supported by theoretical grounding and higher rater agreement. However, ecological validity across therapies, languages, and context fairness across groups and key implementation and maintenance issues such as feasibility, clinician acceptance, ethical oversight models, feasibility, and unintended effects were not addressed. Yeah, so these are the things that were not addressed. Using the taxonomy, future evaluations could go beyond expert ratings by testing validity across modalities, populations, and context, examining reliability across models and raters, and focusing on implementations through usability, clinician-patient co-creation, and ethical integration. Ongoing maintenance would monitor drift, bias, and unintended effects, including impacts on novice therapists, including tool remains, ensuring the tool remains theoretically sound and reliable and clinically sustainable. Now, study for intervention. A clinically grounded framework for evaluating language model assisted cognitive restructuring. Sharma and all conducted a multi-stage project to design, deploy, and as well as evaluate a human language model interaction tool for cognitive restructuring, a core CBT technique. Across all stages, the the project integrated clinical validity, ecological evaluation, safety, and equity considerations. The first stage defined and validated clinically meaningful AI objectives, working with mental health professionals. The authors developed 7 linguistic attributes for reframing, including empathy, positivity, actionability, specificity, and addressing thinking traps. To ensure clinical validity, 600 reframes were collected and annotated by practitioners. A randomized field study on Mental Health America platform showed users preferred highly em- empathic and specific reframes, while overly positive ones were less effective. Interesting. Under the implementation dimension, the framework was operationalized into an interactive language model powered tool supporting users in cognitive restructuring. Co-designed with mental health professionals, it included safety mechanisms such as classification and rule-based filtering, IRB approval, and user reporting function, with flagged content 0.65% confirming filter effectiveness. A large-scale field study on the MHA website, which is Mental Health America, I guess, evaluated user-reported outcomes, including the emotional impact, therapeutic utility, and skill acquisition. The tool showed measurable benefits, with the majority of participants reporting reduced negative emotion and helpfulness of reframes for overcoming negative thoughts. Under maintenance, the third stage assessed equity and found reduced effectiveness for adolescents. aged 13 to 17. Targeted adaptations improved helpfulness in a follow-up trial without affecting other groups, demonstrating ongoing monitoring and refinement. This case study shows how a clinically grounded real-world evaluation framework centered on safety and equity can produce a tool with measurable utility from a taxonomy perspective. It shows validity, reliability, safety, equity, and maintenance. The tool has, yeah, mental health has been deployed by Mental Health America, serving over 160,000. I'll look into this one. This is quite interesting for my own work as well. This is the 5 case study, which is a hierarchical LLM and variation autoencoder tool for clinically meaningful timeline summarization. Very interesting. But I'm sort of tired. Let's forget the study and let's go to moving forward. First video. Or should I? No, let's go. Let's record. How much? It's 7%. That's crazy. Proposed hybrid tool that integrates hierarchical variation autoencoders to meaningful summaries of long-term social media. Oh, this is like this was one of the challenges for a shared task. I think it was CLPSYCH, clinical psychology shared task, like one of that. This ACL. It produces 2 layers: first person evidence summary capturing subjective experiences, and third person clinical summary mapping the experiences to diagnostic indicators, interpersonal patterns, and moments of change. The goal is to help clinicians and researchers synthesize key information from longitudinal mental health data. Interesting. Evaluation of the tool integrated both automatic and expert-based components. Automatic metrics assessed meaning preservation, factual consistency, e- evidence appropriateness, coherence, and fluency. Like these are quite straightforward to even evaluated with the best large language models as judges, and they do really good work on that. Um, Clinical experts rated summaries for usefulness, diagnostic accuracy, and their usability to reflect dynamic psychological processes. Inter-rater agreement ensured the reliability of human judgments, and the evaluation studies tested the contribution of specific model components such as key phrase extraction and expert-informed prompting. This is like fancy word from prompting. Applying the proposed taxonomy shows that construct validity. The work addresses construct validity alignment with clinical constructs and criterion validity through correlations with expert judgments. It also touches on reliability by inter-rater agreement. However, because the tool was trained on and evaluated only on social media data, ecological validity and clinical generalizability is still limited, although the peer support platform provides authentic language. Selective self-disclosure gives the model only partial view of user psychological states. The authors also acknowledge risks such as hallucinations, bias, and unsafe inferences, but do not systematically evaluate them, nor do they assess fairness across demographic or linguistic groups. Well, this is like, again, a very common thing that happens. Implementation and maintenance factors such as Implementation and maintenance factors such as clinical usability, practitioner acceptance, and long-term model stability were likewise not examined. Future work could extend evaluation to generalizability, usability, and sustainability, ecological testing across cultures and clinical contexts, repeated assessments, for reliability, clinician-focused implementation studies, and ongoing monitoring for drift or bias would support consistent performance, advancing the tool from proof of concept to a clinically robust, ethical, and sustainable mental health tool. Now, moving forward, evaluation foundations and maturity pathways. Now, this is basically what we are wrapping up with. Moving forward, evaluation practices in AI for mental health remain concentrated in early stage. Technical validation with relatively new tools reaching implementation or maintenance. While this is typically for an emerging field, it motivates the need for explicit minimum evaluation standards. Yeah, we need that for sure. Um, Evidence of therapeutic benefit and safety. Yeah, a robust evaluation strategy requires multi-layered standardized pipeline in which evaluation depth increases. Oh, this is important. A robust evaluation strategy requires a multi-layer standards pipeline in which evaluation depth increases with tools intended role and potential harm. Yeah, this is important. We distinguish three maturity layers. So yeah, okay, so they define three layers for this. Basically, they are providing solution, which is the early maturity, which is exploratory, validation, accuracy, robustness. Then at an intermediate level, human-centered evaluation, maybe expert judgments, and in the final one, we can probably um, introduce the context and the longitudinal timeline, long-term impact. Yeah, see, including workflow integration, feasibility across settings, so all that. Now, this layered structure is particularly important in mental health settings, while concerns about invasiveness and reduced human oversight and potential clinician descaling are long-standing. And like this is important. Um, or out of 60 randomly sampled papers from, or 68% fall in the early maturity, intermediate, and 32% um, fall in the intermediate. Notably, more recent publications, but really those from the past year, show a growing trend in to involve clinical experts in the evaluation process. And this is the reason for this is because even in conferences, people are like, no, 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 where is the evidence? Like, how do experts feel about this? So that is important. We have to go for IRB as well. So safety, fairness, and adaptability. Safety and fairness require proactive domain-specific protocols rather than retrospective checks. Uh, Practical implications across maturity stages. AI support must therefore remain adaptable to evolving constructs. Again, circling back to the main thing. Um, Constructs and evidence as theoretical advances directly shape evaluation targets, risk assessment, and patient safety. Yeah, these are like very important practical implications across maturity stages. We emphasize that the proposed taxonomy is maturity aware rather than uniform checklist, and this is important because we need to involve different components or different tenants or different domains in which we are going to evaluate the systems that we will be building. And this should also include some of the system design things, the drift, and how should we adapt the evaluation itself. And that is like the core work that needs to be done. And researchers without clinical access or deployment resources higher level can be partially possible through structured patient simulation. Yeah, this is what I'm doing. For researchers without clinical access or deployment higher approximated to structured patient simulations, scenario-based evaluations grounded in clinical guidelines, bias audits across demographic personas, and expert-informed annotation annotation protocols target construct validity and rubric-based um, LLM as a judge aligned. Yeah. While such technical proxies are not substitutes for real validation, they enable early stage work to engage more explicitly with safety validity. Yeah. Calibrate claims appropriate system. And I think this is like an important paper. So yeah, this was the paper at a very high level. They basically discussed a lot of around 135 papers they surveyed and the pitfalls of the evaluation. What are the different ways and in which papers evaluate? What are the things that papers miss? And what are the things they do correctly? They beautifully tie the classical psychometrics, which is the old ways, and the LM as a judge, the new ways, how we can integrate them. And I think this does provide a lot of new insights, especially for me. Like there were certain components in red which I did not cover, especially in this video, which I didn't understand. So like there was no point for me. So what I'm gonna do is I'm gonna read about this as well and post it in the description. But the overall idea is so the evaluation should not be just be static. It should cover the fundamental principles, the old classical theory. It should not be biased. If you're building chatbots, it should not be biased to your specific task. Demographic and cultural aspects came quite often in this paper. Be mindful of those. And how does your chatbots or how do your systems prevent drift, and how do your evaluation um, mechanisms account for the drift in the real world data space. I think I'll leave at that. That's the most important thing. Thanks for being part of the video and really appreciate it.